we begin with our first panelist, Dr. David Gillam, who will be speaking on the diagnosis and management of dentine hypersensitivity. So David, from the literature and your experience, what are the barriers in diagnosing dentine hypersensitivity?
Before I answer the question, I'm just going to briefly explain. You can see on the slide what dentine hypersensitivity is. It's a well-known clinical condition, and the underlying mechanism involved in this is the hydrodynamic theory, which promotes two approaches for treating the problem. You either occlude the tubules, which are open on the root surface, or you use toothpaste or mouth rinse. Basically, it's to do with fluid movement through the open dentinal tubules, which affects a response, a painful response. Now, if I go now onto the challenges that might impact on both the dentist and the patient when we experience diagnosing dental hypersensitivity, let's look at the clinician's point of view. What do they think about the problem? Well, from the literature, we find that most of the dentists seem to think that dentine hypersensitivity has a mild to moderate impact on their patients' quality of life. And also from the prevalence data, depending on whether or not we use clinical exam or questionnaires, we find that the problem may be underestimated or overestimated. But one of the problems, I think, is that what exactly is the true impact of the dentine hypersensitivity on the quality of life of patients who complain, and is it adequately diagnosed or treated? And furthermore, can dentists adequately diagnose it from other dental conditions which may have similar pain symptoms? And one of the other things which came through on the various surveys in the literature was that are clinicians really confident in successfully managing the problem in daily practice, and do they actually monitor it in daily practice? And so the problem from the clinical point of view is that clinicians do not appear to routinely screen or examine their patients for the dentine hypersensitivity unless the patient prompts them. Now, from the patient's perspective, what do they consider dentine hypersensitivity to be? Well, again, from the literature, it seems to be a mild transient pain that does not impact on the quality of life. And most patients do not even bother to treat dentine hypersensitivity. Those that do may self-treat with sensitivity or use coping mechanisms to avoid aggravating the problem. And from the literature, it appears up to 50% may not even attend or consult a dentist. Now, is that because of fear of the dentist, anxiety, fear of discomfort? Or is it due to barriers to dental treatment, cost, time, availability of appointments? But the outcome is this: patients either do not consult a dentist, they do nothing, or they self-treat. However, there's undoubtedly patients with dentine hypersensitivity who experience moderate to severe pain, which does impact on their quality of life in daily living. I hope that answers the question, Victoria.
Thank you. So what should dental clinicians of today be looking for in the materials of choice to treat dentine hypersensitivity?
Yes, this again is a very interesting question. One can approach it in two ways. The professionally applied products, such as varnishes, desensitizing polishing paste. More invasive treatment might be glass ionomer, composite materials. You can also use laser, and in some cases laser therapy, and also if they're having periodontal surgery, you may obviously use flat procedures as well. So there's a lot of innovation now with minimally invasive treatments now for toothpaste. Again, there are a number of relatively new innovations of toothpaste, but generally speaking, they are tweaks of previous systems. The stannous fluoride, strontium chloride, hydroxyapatite toothpaste, and more recently, there's been development with the bioactive glasses. Some of the people listening would obviously be aware of Novamin, but also more recently, there's another bioactive glass called BioMin F, a development which we were involved in at Queen Mary, and I would just briefly touch on that, if I may. Other products which have been recommended, but are high fluoride products. So it's not just the simple 1100 or 1450 parts per million, it's 2800, 5000. And this is generally used for protection against root caries. And what I would say is that whether you have a low fluoride of 1100 or high fluoride, when you look at the fluoride release profile, within 30 minutes, most of the fluoride is diluted down, so it doesn't protect the teeth over a longer period. And to address this issue, the development within Queen Mary was with a special glass which we call BioMin, which the fluoride is contained in the glass. It's a lower level of fluoride. It releases calcium, phosphate, and fluoride ions, and it can be used for dentine hypersensitivity, but also can be used in remineralization. Now, the advantage of this from our laboratory studies is that because it's a slow release, it lasts over 12 hours, which is ideal. And it fits in with the concepts that Tenkati says of using a low level of fluoride, which is sustained over a longer period of time. And the other advantage is, to our mind, that it produces fluorapatite rather than the more soluble hydroxyapatite, which is much more acid resistant. And you can see from the micrographs that we have here, there's 3 on the screen: before treatment, after treatment, and after acid challenge. And it's quite clear that from our studies, particularly laboratory studies, that it does block the tubules, it reduces fluid flow, and in that sense, it will reduce the discomfort, but also, more importantly, it will reduce the loss of tooth tissue from acid attack. So while we would say that this is a novel procedure and toothpaste, what we would say that simply giving a toothpaste without modifying and advising the patient on other factors which cause the problem in the first place would be wrong. So we'll come on to this in a moment, but I hope that's answered your question for the time being. If we go on to the next slide, please.
Thank you, David. So what would a full diagnostic test include for dentine hypersensitivity and an optimal treatment path?
Right, thank you, Victoria. Well, if we talk about the diagnostic test first, and then we'll move on to the treatment path slide afterwards. Firstly, I would say there are 2 types of patients which we broadly deal with in clinical practice. There is the patient who is new to the practice, who's never been seen, and also the patient who attends on a routine or regular basis. Now, with the first category, you don't necessarily have a prior history of medical and dental, dietary and social. So you have to spend more time on screening them for this. You then have to use cold air and a probe to identify whether or not they have sensitivity. If the symptoms are unclear, you may have to spend time looking at differential diagnosis. And again, if they're a new patient, you're looking for things like caries, recurrent caries, cracked teeth, and so on, which will take time. Once you have done your various testing, you might have to use special tests with this type of patient. You would then make a definitive diagnosis based on the presenting features. And then you can go on to your management strategy, which we'll come on to. On the other hand, if you have a patient who is known to you and it's recently had, for example, scaling debridement, periodontal non-surgical treatment, then you would know that the discomfort has probably come from the procedures that you use, what we would call post-operative sensitivity. This is probably the same if they've had a bleaching or whitening session, they may come back and complain about sensitivity. So again, you can look at the clinical features, and because you have the history already, it may take you less time to diagnose the problem. So you would use the same diagnostic tests, a simple cold air blast. Then you would ask the patient to score it on a scale of 0 to 10, and 0 being no pain and 10 being the most uncomfortable pain. And then you could then, if you want, use a varnish or a toothpaste, and after 5 minutes then reapply the test and see if there's a problem. And if they still have sensitivity and the score is pretty much the same, then it's likely that it may not be dentine hypersensitivity. However, if it's been reduced in severity, then it's more likely to be. Now, on to the management strategy. Again, depending on the severity of the problem, will determine whether you will give an immediate treatment, professionally applied, or you would give them a toothpaste. And then you would ask them to come back on another visit, if possible, and see whether the symptoms have been alleviated. What you can do is also give them a pain diary and ask them to comment on whether the discomfort has been reduced during the time after that you've given the treatment. If it's been successfully treated, then you just simply give further recommendations on what type of toothpaste they can use, toothbrush modification, and so on, and then monitor them as and when you think you need to see them based on the toolkits that we can use. If there's still sensitivity, then you would have to go on further with more invasive treatment. So if we go on to the treatment path now, please. So again, this is a model which was developed a number of years ago. It was originally based on the WHO pain model. Robin Orchards and I use this in one of our publications. And really, it's a stepwise approach to treating or managing sensitivity. And it goes, and really it fits in today with a minimally invasive treatment. So first of all, you would screen for dentine hypersensitivity if it's diagnosed. Depending on how severe it is, you eliminate the etiological or predisposing factors. You may give them a desensitizing toothpaste or mouth rinse, and you would also do various recommendations with oral hygiene management, reduce any potential aggressive or overzealous toothbrushing, particularly with if they're using high levels of acidic drinks. You need to try and separate that to prevent any further tooth wear. So that would be the basic for level, what we call level 1. If, however, after you see them again, the pain persists, you may wish to use topical agents, fluoride varnishes, which we've already alluded to, and or desensitizing toothpaste or mouth rinse. Again, you include the prevention strategies that you've developed, and that would include dietary advice. If, however, the pain persists, you may want to use a more invasive strategy, restorative materials such as glass ionomer cements, composite materials, and you may have patients, those of you who are periodontists, and you may be doing periodontal surgery. You may need to use that to correct gingival recession with or without sensitivity. Now, each of us must assess whether the problem is mild or moderate, generalized sensitivity, or moderate or severe localized sensitivity. The severity of the problem will determine whether the treatment is more invasive, and that's key. So it's not just simply giving the treatment or procedure, it's altering the patient's behavior and modifying what they do within the day-to-day lifestyle. Now, I think finally what we need to address as clinicians, and also for the patient's perspective, if we want to improve the quality of life, we have to acknowledge that we might not get pain down to zero with our treatment. So we have to manage our expectations as well as the patient's. Now, to my mind, if we can reduce the level of discomfort to a level in which they're able to cope in their day-to-day practices, rinsing, eating, and so on, I think that's still a benefit. So please remember, don't just give a toothpaste or a procedure without giving the additional preventive advice which we've discussed in this session. The other thing I would like to say, I'm not trying to enforce you to spend extra time which you may struggle to fit in your daily practice. What I would like you to do is look at the principles that I've outlined in this session and apply them to your practice. And I hope that will help you monitor the condition, but also alleviate your patient's discomfort in a way that enables them to have a better quality of life. Thank you very much for listening.
Thank you, David.